Chronic liver disease refers to long-standing liver dysfunction with complications of portal hypertension and hepatic decompensation. Decompensated chronic liver disease presents with ascites, variceal bleeding, hepatic encephalopathy, and renal impairment. Initial evaluation includes history of alcohol use, hepatitis risk, confusion, melena, fever, and abdominal distension. Physical examination shows jaundice, spider angiomas, ascites, hepatosplenomegaly, and altered sensorium. Ascites is classified as mild, moderate, or gross, depending on abdominal distension and ultrasound findings. Serum ascites albumin gradient greater than 1:1 suggests portal hypertension as the cause of ascites. Neutrophil count in acidic fluid greater than 250 cells per cubic millimeter indicates spontaneous bacterial peritonitis. Acidic fluid protein less than 1 gram% indicates need for SBP prophylaxis in high-risk patients. Acidic protein greater than 2.5 grams% suggests cardiac or vascular causes like congestive heart failure or Budd-Chiari syndrome. Management of ascites includes sodium restriction below 2 grams per day and diuretics like spironolactone and furosemide. Large volume ascites requires paracentesis with albumin replacement when more than 5 liters are removed. Refractory ascites requires repeated paracentesis and discontinuation of non-selective beta blockers if present. Spontaneous bacterial peritonitis is diagnosed when acidic fluid neutrophils exceed 250 per cubic millimeter. Treatment of SBP includes third-generation cephalosporins like cefotaxime and albumin infusion to reduce renal failure risk. Variceal bleeding is managed with resuscitation, octreotide or terlipressin, antibiotics, and urgent endoscopic band ligation. Primary prophylaxis of varices includes non-selective beta blockers or endoscopic band ligation, depending on variceal size. Hepatic encephalopathy presents with confusion ranging from sleep disturbance to coma in severe cases. Treatment of hepatic encephalopathy includes lactulose titrated to 2 to 3 soft stools per day and rifaximin if refractory. Renal impairment in cirrhosis requires stopping diuretics, albumin infusion, and evaluation for hepatorenal syndrome. Hepatorenal syndrome is treated with albumin and vasoconstrictors like terlipressin or noradrenaline infusion. Hyponatremia in cirrhosis requires stopping diuretics and correcting severe cases with albumin or hypertonic saline. Coagulopathy is treated only if bleeding occurs with transfusion of plasma, platelets, and vitamin K when indicated. Nutritional support includes high-calorie intake and adequate protein of 1.4 grams per kilogram per day, even in encephalopathy. The key takeaway is that decompensated chronic liver disease requires coordinated management of ascites, infections, bleeding, encephalopathy, and renal failure to improve survival.